Two big topics, and I've condensed them both into one talk. So we're just going to talk a little bit about posterior capsule, how to protect it, and then vitreous loss. And then Dr. Barquet is going to talk about the sort of techniques of managing vitreous loss later on. So why is this important? We're going to talk about that. A few anatomical reminders to aid you in handling the vitreous. We're going to look at some maneuvers to avoid while you're in the anterior segment. Two prevention techniques that will reduce your incidence of posterior capsule rupture significantly. That's risk stratification and silicone tip, IA probe, and we'll talk about those. And then how you get experience of managing vitreous loss. It happens one time, we tell the patients one time in 100, it's actually closer to 1 in 50. But how do you get experience of it if it happens so infrequently? So why is it important? Well, these are the 5 complications that we see: suprachoroidal hemorrhage, cystoid macular edema, glaucoma, endophthalmitis, and retinal detachment. And it's still, therefore, potentially a disastrous complication. For example, the risk of retinal detachment, as I said yesterday, is 40 times higher after vitreous loss. The anatomical relations I want to talk about are the retrolental ligament, and you'll also notice there's a thing called the anterior ciliary ligament. These are the zonules here, and the ciliary processes, and the posterior ciliary ligament. And again, you can see how intimately bound up this is with the zonular processes, the zonules themselves, the ciliary body, and the vitreous base. And then this lovely video from Jan Verst, who is a Dutch ophthalmologist who died a couple of years ago, where he injects orange paint into the vitreous cavity of the human eye. And what this shows quite clearly is how interconnected everything is in the vitreous. So you can imagine if you do something to the vitreous here, it's interconnected with this whole mass of tissue. Now, normally it's invisible, it's transparent, so you don't see that. But every time you touch a bit of vitreous, it's connected to the whole of the rest of the vitreous. You've got to remember that, and the vitreous base is inseparable from the retina. So how do you look after the posterior capsule? You'll remember this video, hopefully, I showed yesterday, and this is a surgeon who is doing something which we now teach our residents never to do anymore, and that is to use a second instrument in the eye while you're removing the last fragment. Now, we're all taught you keep the second instrument in to protect the posterior capsule. In fact, the reason that you need a second instrument at all is because you've got a second instrument in the eye. And what happens is that when the second instrument is in, you get excess leakage from the side port, and Brian Little has worked out that you get 65% more fluid loss through the side port than if you don't have the instrument in the eye. So you can reduce your fluid usage by 65% simply by not using a second instrument so often. So you get leakage from the side port. Watch what happens here. Because of that leakage, you get instability, and the capsule bounces around. It comes into the phaco probe. The phaco probe makes a hole in it, and at this stage, as we said yesterday, there's a nice little triangular flap, which if you tamponade with viscoelastic, you can control and perform a posterorexis. What this surgeon does is the wrong thing, and that's to take the instruments out, decompress the anterior chamber, and get vitreous coming through that hole and expanding it. 40 times increased risk now of retinal detachment. Similarly here, you can see a surgeon using a Simcoe probe to do irrigation aspiration. And what I want you to notice is that, because the surgeon didn't notice it, unfortunately, is this maneuver here. And you can see here, that's not the edge of the soft lens matter, that's the edge of the capsule. So he's disinserted all the zonules by pulling too hard with that Simcoe, and he's actually torn the capsule off the zonular apparatus. This next video shows a maneuver that really should be avoided. So this is a Rayner Centerflex lens going into the eye. They're very good lenses, they center very nicely. But what the surgeon notices at this point is that the lens upper haptic is out of the capsular bag. So he's doing all sorts of maneuvers to address that. And you'll see here there's a dialing hook that he's using to manipulate that lens upper haptic into the bag. Now you can imagine that this haptic over here is coming out of the left ear somewhere. He's pushed it so hard. And the zonules on this side are also being stretched unimaginably and probably being torn. Now, you might not think that matters, but actually what happens at the end of this procedure is the surgeon notices now there's a little bit of a vitreous strand just there that he's picked up with a sponge. So that vitreous has come around the side of those torn zonules and is now in the anterior segment. You should never do this. This is a bad maneuver. It just causes traction on the vitreous base. And although this ended up okay, what this surgeon is now doing is putting in Myocol or acetylcholine and using the peaked pupil sign. Again, you should never do this. It's just putting traction on the vitreous base. We're all taught to do it, but it's a bad maneuver. And what you should do is an anterior vitrectomy, which he's now doing. But what he hasn't done is use triamcinolone. So he can't see that he's removed all the vitreous. And unfortunately, this patient walked in 2 days later with a macular off-retinal detachment in her only eye. So these maneuvers in the anterior segment can be quite damaging to the zonular apparatus, the posterior capsule, and be a problem. Now, I talked about removing the second instrument. Here's an example where the second instrument is supposed to be protecting the posterior capsule, but actually damages it. I'll run this on forward a little bit. But you can see at the end of the procedure that there is, sorry, wrong video, this is the one. There is actually a hole in the posterior capsule caused by the second instrument, just there. And so the second instrument, the teaching is it protects the posterior capsule. It just causes increased leakage. That leakage causes instability, and that instability will often lead to damage. So what do? When you get to remove the last fragment, you take the second instrument out. What then happens is you can see all the leakage occurring out of the side port here. That leakage stops. And what you've then got is a closed system. The only place where things can go is into the phaco-tip. There is no other escape from the eye. So you have a completely stable chamber. Fluid comes in through the irrigation port and out through the phaco-tip. So we now teach routinely, when you get to the last fragment, take the second instrument out. It feels very counterintuitive, but try it and you'll love it. And you'll find you've got a deep chamber, it doesn't bounce around, and it's a much safer thing to do. Capsular block is another thing to try and avoid. It usually happens where you have a small pupil and therefore a small rhexis and a hard cataract. And what happens with a hard cataract and a small pupil and a small rhexis is that fluid goes behind the nucleus, lifts it forward, blocks the rhexis, stops egress of fluid out of the rhexis, and causes, as you inject more and more fluid, causes the posterior capsule to pop. And you'll see that now. You'll see what's called the pupil snap sign. So as the surgeon goes under, you'll see the iris lifts forward and then suddenly pops backwards. So there it goes. That pupil snap sign means the posterior capsule's blown out. And you'll find that if you carry on doing a phaco, as this surgeon does, you get what's called an early red reflex as the nucleus sinks into the vitreous cavity, and you get that same feeling in your stomach as it goes down. That's what will happen. So if you see that sign, if you see pupil snap, the posterior capsule is gone, you need to deal with it. And that's just a cartoon showing the same thing. Fluid goes in, lifts the nucleus against the rhexis, blocks it off. If you carry on injecting, then you get a posterior capsule pop. Now I'm going to talk a bit about risk stratification. This is a graph, quite an old graph now, from 1963 to 2003, showing the rate of increase of cataract surgery in England. And you'll see round about 1989, it took off in a big way. Now, that's when I started ophthalmology in 1983, and that's when I became a consultant. And you can see the sudden and dramatic effect I had on the cataract surgical rate in England. Admittedly, there were a few other people doing the same thing. But the point about this is cataract surgery is becoming much more common. People are living longer, getting older, developing more cataracts. We intervene earlier, and so it's a very common procedure. John Sparrow, who's a professor in Bristol, did some very good work analysing 55,000 cataract operations and looked at the complications that occurred. And what he specifically earmarked here was that posterior capsule rupture vitreous loss was occurring in 1.92, that's 2% of cases, 1 in 50 cases in the UK when this was done. He's now analysed over 1 million cases using the National Cataract Data Set and has very firm data. So what he then did, he calculated a tailored risk score for each of those complications, and here they are. So even being unable to lie flat gives you an increased risk of posterior capsule vitreous loss. And these are in ascend or descending order. You'll see down at the bottom, trainee surgeon, 3.7 times the risk. So 4 times the risk of losing vitreous if you're a trainee surgeon. And all of these things are important in terms of recognizing them as a risk for losing vitreous. What he then did was he took these composite odds ratios, and if you multiply them together, all these risk factors, you get a predicted probability of the vitreous loss. So, for example, 2 of those risk factors, 90-year-old surgeon, female patient, and the predicted probability of vitreous loss, 1.7%, because you've multiplied those two risk factors together. What though if you have a male patient, we all know that life is much more difficult for males, more than 90 years old, celiac exfoliation, glaucoma, white, all these risk factors, and they can't lie flat, you multiply all those together and you get a predicted probability of vitreous loss of 44%. So that patient is almost as likely to lose vitreous as not. So a chap called Tom Butler from Great Yarmouth, who's actually a very good Cornell speaker if you need one for next year, he took those scores and he gave them numbers, and we've now incorporated those numbers into our cataract listing form. So here are each of those risk factors that John Sparrow found, and he's given a score to each of them. And every patient that comes through our door for cataract gets risk scored, and if those scores add up to 3 or more, a consultant has to do the case, or a senior surgeon has to do the case. So we risk stratify all the patients, we know who are the complicated, potentially complicated ones, and we give the easy ones to the junior surgeons. And has that made a difference? Well, we did a study looking at 3 years before we scored and 3 years after, and we found that our PC rupture rate dropped by 20%, simply by risk stratifying all the patients. Everyone still lost vitreous, but the trainees, the vitreous loss rate took a dive, and that was because we were giving them appropriate cases to do. This was the timing of the vitreous loss, so you can see mainly it occurred during phacoemulsification, but also during irrigation aspiration. And what's really important about this is that we then switched to having a silicon-tipped coaxial tip. Here it is. I have no financial interest in this at all. We just happen to use it. And what we found after we introduced this is we never break posterior capsules now during IA. It just doesn't happen anymore. This is a really safe instrument. If you grab the capsule with this, it does not tear it. Whereas metal instruments, often the edges become a bit rough with time and they will break the capsule. So we've now cut our vitreous loss rate during IA to 0. We can break the capsule at every other stage of the procedure, but not during IA anymore. And there's the graph showing that. Silicon tip, we just don't break the capsule anymore. So those two things, risk scoring and silicon tip IA, have reduced our vitreous loss rate by 20%. How do you get experience of managing vitreous loss? Well, buy these model eyes. You can go on the simulated ocular surgery website now and you can buy eyes that you can do intraocular injections, you can do vitrectomies, you can do cataract, you can do squints, you can do scleral buckling, whatever you like. In your own operating theatre. So there are no animal eyes here, these are plastic. You can take them into the operating theatre, you don't even need a wet lab. And here's a video of me doing a wet lab training session with the regional trainees, so they come from all over Oxford region, and I show them first of all how to do cataract surgery and anterior vitrectomy with these model eyes, and then they can all have a go. And the nurses get used to setting up the machine, and the juniors can get used to setting up the machine. So here I'm doing phaco, and then we swap over and do a vitrectomy. You can inject egg white into these eyes to mimic the vitreous, and you can stain it with triamcinolone. And you're in your own environment, and everyone can have a go at setting up the machine, learning the settings, and talk it through and practice. We do this now once every 4 to 6 months with all the trainees, so they each get a go at actually doing an anterior vitrectomy, which is invaluable because you only do it one time in 100 otherwise. So in summary, remember your anatomical relations, protect the posterior capsule and the zonules by not doing things in the anterior chamber that you shouldn't do. Certainly don't pull on the vitreous, and Dr. El-Baki is going to talk about the settings and everything for vitrectomy later on. Always use triamcinolone, I think, to stain the vitreous, and if you just implement risk stratification and a silicon-tipped IA probe, you'll reduce your vitreous loss rate significantly. And as I say, we're going to details of how to do an anterior vitrectomy coming a bit later. Thank you very much.